All right, so the matrix is where the action is. This is where the nail is being formed. Therefore, anything that causes inflammation of the matrix is going to give you an abnormal looking nail. The eponychium is basically the cuticle. And we know the significance of the cuticle. The significance of the cuticle is to present the water seal, the water barrier, to prevent water from getting down here and affecting the substance of the matrix. And then, of course, there's the nail itself, the nail plate. The hyponychium assumes some importance here because that is a common way for you to get fungus getting into the nail bed. And the nail bed is the seat of the activity in the most common type of fungal infection that you will see, which is dermatophyte disease. Okay. So, when we speak about onychomycosis, we're really talking about fungal infections irrespective of etiology, whatever causes it. All fungal infections, but onychomycosis. The most common one is going to be dermatophyte disease. It contributes to 90% of your toenail infections, 50% of your fingernail infections. That is also what we call ringworm, tinea unguium. So those are your dermatophytes. Then we go on to the yeast. And the yeast will cause 20% of our fingernail infections. That is the paronychia. Most commonly Candida species, others of course. And then there are the non-dermatophytes, which we will spend no time on today because those, as you can see, contribute very little to our disease. Now I want to say that 50% of abnormal looking fingernails are due to fungal infections. What I really want to say is only 50%, meaning that when you see an abnormal nail, you must not automatically assume that this is due to a fungus. So here we're speaking today, when we're talking about onychomycosis, of tinea unguium and chronic paronychia mainly. That's basically going to be the substance of the presentation today. Okay. When we look at the predisposing factors for tinea unguium, and bear with me, stay with me here, I'm going to spend the next couple of minutes speaking about tinea unguium, and then I'm going to speak about chronic paronychia. When we look at the predisposing factors, basically anything that can predispose you to a fungal infection of the sole of your foot is going to also predispose you to a fungal infection of your nail, simply because that access point that I mentioned earlier, the hyponychium, once the sole of the foot is involved, you get now access under the surface of that nail, and then you get involvement of the nail bed. Additionally, anything that is going to slow up the growth of the nail. So the fungus grows, infects against the strain of growth of the nail. So anything that slows up the growth of the nail is going to give, basically, very crudely put, a longer time for the fungus to set in, so to speak. So diabetes, circulatory disorders, anything that is going to slow down the growth of that nail. Immunosuppression speaks for itself, advanced age, slower growth of nail again. Anything that is going to cause the environment of the nail to be warm and moist. That will support softening up of the keratin, making the fungus easier to penetrate the skin. And so, as I always like to say, the people who walk barefoot on the road for a long time are less likely to get a fungal infection than the people who do repeated manicures. Okay. Nail disease. How does nail disease do that? By distorting the normal architecture of the nail. What it does is it encourages your fungus to take hold, because the structure and function which keeps the nail intact is out. So previous nail disease due to psoriasis will also predispose you to a fungal infection. Shared bathing facilities, baths, students in a boarding situation, shared bathing facilities. Your pedicure basin also now becomes a shared bathing facility simply because of your greater exposure to contagion. And trauma. Trauma, again, because of distortion of the normal architecture of the nail. So athletes are a subpopulation that are at slightly greater risk for getting fungal infections as well. And lastly, circulatory disease, occlusive footwear, which we spoke to already. All right, so this is just to dramatize it and just to keep you a little awake. This is web space disease, two different presentations of tinea pedis. Web space disease, quite severe, and then the dry moccasin foot. The moccasin foot there, if you notice, there's one foot involved and the other not. That is pretty classical of tinea pedis, and that certainly is going to set you up for a fungal infection of your nails later on. Now, when we look at the nail changes in fungal infections, I like to categorize it as secondary infection, secondary changes, secondary criteria, because there are some things which are not pathognomonic of fungal disease. And that's what I call secondary criteria. You can see them in other fungal infections apart from tinea unguium. So you can see it in non-dermatophyte disease. You can see it in chronic paronychia. But you can also see it in non-fungal disease. So some of these you can see in psoriasis. You can see it in lichen planus of the nails. You can see it in 20-nail dystrophy and so on. These are not classical of a fungal infection. And these are thickening. And thickening and discoloration is really frequently what we refer to as dystrophy, as you know. So dystrophy of the nail is not classical for fungal infections. Subplate keratosis, subungual hyperkeratosis, and that is that buildup of keratin, that thickening that you see when you look underneath the nail, and you know that is not just regular debris, that is necrotic keratin. That also is seen, for instance, in psoriasis. So you can't look at that and say, yeah, man, this is it. And then onychomycosis. Onychomycosis, separation of the nail from the nail bed. That lifting, when they can use something and go all the way down. When the nail plate is no longer in contact with the subungual tissues. And really, the reason I want to call that to mind is that that is very important when it comes onto treatment. When your nail is no longer in contact with the nail bed, it means that the diffusion process which takes place. Okay, let me step back a little bit. If you were to rip your nail from the nail bed, you would bleed. And the reason for that is because the nail obviously is just not sitting on the bed. There is a communication, a vascular communication between the base of the nail and the bed. And that is what supports the diffusion process of your oral antifungal. And so if you have lifting of the nail from the bed, that diffusion becomes impaired. And so this actually now makes your treatment less effective. So that's it. That is a distal and lateral separation, which, by the way, can also be seen in psoriasis. Now, when you see these, you will know for sure that you have a fungal infection. Unfortunately, these don't necessarily always present. And this is what I call fungal foci, foci of fungus, in the form of dermatophyma and lacunae. The dermatophyma is a dense, it's a very thick mass. It's when you look at it, you see a lot of white, thick stuff. And what all of that is really necrotic keratin. And the real problem with that is that it really secludes the active fungus away, protects it from your oral antifungal. So when you have that, you have active fungus somewhere deep inside that dense, thick wall mass, which really isn't even getting much of your oral antifungal when you give it. here, you see these as tiny streaks. What there are channels in the nail, and the hyphae are inside there. And this is really due to enzymatic activity of the fungus. And what happens is that you get a nice big channel created, and with just a little bit of fungus inside there, and that also helps to protect them, so to speak, from your oral antifungals when you give it. So these are all definite evidence of fungus when you find it, and also a challenge for treatment. Yeah, go through all of those, yeah, and then go to the next slide. Okay, top one, okay. So this is what happens. So we go here from the hyponychium and we come like that, and when we go spread proximally. Most common presentation that we will see. Superficial white. Superficial white is invariably toenail disease. And what happens here is that it penetrates the surface of the nail like that, okay? And then it enters into the substance of the nail. And what you get are tiny white patches which gradually coalesce. And when you look at it, it looks like something that you could scrape off. And that actually is what you can do with it. In proximal subungual, the penetration takes place via the proximal edge here from the proximal nail fold, gets into the matrix. You're going to invariably have dystrophy in something like this. And then it goes like that into the substance of the nail. So that comes in from the proximal end, and although we're speaking here about tinea unguium, you can actually see this presentation in the paronychials. So that's it here, proximally. And it tends to be exactly there. My pointer isn't moving. I'm using the bottom line. Right. So with endonyx onychomycosis, the surface infection takes place, and then you get deep nail invasion, and you get splitting of the nail, and so you get this through and through presentation like that. Now, with total dystrophic onychomycosis, this is really the most advanced form of presentation, and really basically just represents end-stage disease from any of the previous ones. The nail is invariably very markedly dystrophic, and the nail crumbles. You see something like that. Okay. All right. So all of that was intended really to sharpen the focus on just what we really need to look for. Support. And if we're going to use the support, we need to help the support as well. If you're sending a sample to the lab, you need to send a nice sample. By nice, I mean you need to send enough. If you send too little, and worse, if you send it, I mean the ideal sending should be on a piece of black paper. Not likely to have that anywhere in your office, but that at least certainly would help them to see all of the bits and pieces of this white stuff that you're trying to send. But you need to send enough. And apart from enough, you need to sample the right spot. The more distal you sample, it's the less likely they will be able to culture anything from it, because you're going to have a lot of dead necrotic debris. The more proximally you go, is the more likely you'll be able to get something from viable tissue. So, clip as far proximally as you can. Try to get a little subungual material, preferably. So you can do that by curetting or using the blunt edge of the blade underneath. And you must also remember that in superficial white, you should scrape the surface of the nail, because that's the primary invasion. And if the patient has onychomycosis, cut back the nail and try to get stuff from the bed. And remember, the bed is no longer that nice soft bed anymore. It's a little bit hyperkeratotic, so it can take a little bit of. So that's the sort of thing you want to do. Okay, so for an office, what support can we also get? Direct microscopy and dermatophyte test medium. Dermatophyte test medium is basically intended for culture. These you can purchase. They used to have some in Jamaica. I'm not sure if we can still get them locally. We always get ours from a lab and supply company, but they're not hard to get. And first of all, with direct microscopy, you obviously will need a microscope. Many of you have, I know, 15 to 30% potassium hydroxide. What the potassium hydroxide does is that it breaks down the keratin. It softens up the keratin. The dimethyl sulfoxide further speeds that up. And if you don't have DMSO, you should warm it a little bit, because then you can do it right away as opposed to waiting for a couple of days for you to do that. Stain with Parker's blueback and look for spores and hyphae. So that's what you want to. Failing that, you can do the dermatophyte test medium culture, where you inoculate it into these tiny little glass bottles which you can keep in the office, and you observe the color change from yellow to magenta. You do have higher false negatives, than with Sabaros, dextrose, agar, which is the gold standard for culture. And unfortunately, DTM does not identify which species you have. Dermatophyte present. The traditional culture, of course, is with Sabaros, and you need to culture those at room temperature for about 3 to 6 weeks. 6 weeks because you have some slow growth, take a little time. And we plate it with and without cyclohexamide. The cyclohexamide is there to basically kill the contaminants. Those may have come in through handling, improper handling, and so forth. And if we are to have pretty feet, these are